Good evening, everyone. My name is Steve. I'm a volunteer with Firefighter Aid to Ukraine, and I just want to take a few minutes tonight to talk to you about managing a patient's airway at the point of injury. Now, airway injuries can be very, very serious. Things like burns or penetrating trauma, sometimes there's not a lot we can do working out of an individual first aid kit. However, the biggest threat to our airway can actually just simply be blood or our own tongue. So one of the things that we need to understand about the tongue is that it's a big voluntary muscle, and when we go unresponsive, that muscle relaxes. And if you take a look at my prop here, you can see that we have the tongue, and immediately behind it we have our trachea. When we go unresponsive, our tongue just simply falls across that and occludes it. So we have maneuvers like head tilt chin lift or our jaw thrusts that are just good first aid. However, on the battlefield, we don't have the time and the hands to simply hold head tilt chin lift. And the other thing with those is that we can't drain the airway because we may need to drain vomit or blood. So our first go-to positional treatment is to actually just use the recovery position. And most people have seen this in first aid courses or in even things like swimming lessons for us here in North America. Now, what the recovery position does is when we put the patient on their side, that will remove the tongue from the back of the airway. Gravity pulls it towards the side of their mouth, and it will also allow fluids to drain. Now, it's imperative that we understand that in the field, we can never leave an unattended patient on their back. Okay, if someone is on their back and they go unresponsive, their airway will be occluded. So keep in mind, if we're going to walk away from patients in the field, we need to make sure that they're on their side, as long as they're comfortable. The problem is if anything changes with their level of consciousness, we can have that airway obstruction. So the best way to move someone into the recovery position is to take the arm closest to you, just simply put it over their head. Now, I know my mannequin doesn't move quite like a real person, but I think you'll get the point. Then we're going to take the leg that's furthest away from us. We're just going to put the knee up. I'm going to grab this knee, I'm going to grab their other arm, put it up to their cheek, and I'm just going to roll them on their side. Now we can simply move their other arm under their head like a small pillow. Now our patient's airway is protected from fluid or from their tongue. Okay, so remember, no one gets left on their back. Use this recovery position wherever you can. The other thing that you folks are being sent that is very helpful is an NPA. Now, like I mentioned, this is working out of a small aid kit that's on your belt. NPAs are very helpful because what they do is they just simply go through the nose, around the back of the throat, and create a tube between the tongue and the trachea. So they're very simple to use. This NPA is adjustable. It's got a small flange that we can use to change the size. The diameter of the tube will fit in most adult patients, probably a lot of pediatric patients as well. The key is how long do we make it. Now, when we measure an NPA, we want to picture it actually sitting in the patient's airway. So we're going to measure from the tip of the nose to the earlobe, and you can kind of visualize how that would actually sit in a patient's airway. Now, how do we place it? The nice thing with these NPAs is they're pretty much sized to most adults. So if our patient was smaller, all we would do is adjust the flange up and down the tube, okay? But this guy, if we measure it tip of the nose to the tip of the ear, it's pretty much about the right size. So ideally, we want to use the patient's right nostril because we have this bevel here. This bevel just allows the NPA to be placed a little bit easier, but we can use the other nostril, which we will talk about. We need to make sure that we use lube. Now, I know there's a lot of talk of using spit and blood and things like that, but the best clinical practice is to use lube. If you have an NPA in your IFAC and you got room for it, you have room for lube. Okay, we don't need to lube up the piece that will be outside of the patient's nose, and we don't want to stick lube into the tube. We just want to lube the outside. And if we go about halfway, that should be sufficient. Now, one of the big issues when people place NPAs is they want to go up. when in fact we want to go kind of straight down. Okay, so we want to use that bevel, get ourselves into the nostril, and we're just going to push straight down. Now we need to make sure that we don't push from the top. We need to kind of be close to the nair. So we're going to push down, push down, push down. We're going to feel it fall into place. We can take a peek to see if we can see it there. My mannequin doesn't work too good for that, but I know that my NPA is in place because it's fully in there. Okay, now we have an adjunct between the patient's trachea and their nose, which means that that tongue should not occlude the airway. If for some reason we can't use that right nostril, no problem. This NPA is very flexible. We'll simply move to the left nostril. We'll start with the bevel towards the middle. Again, we're gonna still try to work straight back. And then as we feed the NPA in, we may just have to do a small turn, little bit of push, and we should be able to drop it into place, okay? That being said, can we use 2 NPAs? Absolutely. Can we use an NPA and place a patient in the recovery position? For sure.